Okay guys, in this video we're going to go through a passive accessory intervertebral movement of the cervical spine, so an assessment, PAIVMS assessment in a prone position. So Glenn, how would we do that?
So this is the traditional position that PAIVMS is normally taught in. So I'm going to go through a more traditional approach to doing the PAIVMS. We've done another video on a supine position which I quite like clinically, and we'll go through the more traditional method now, and then we'll have a little discussion as to some of the points that will arise from that. So Karina's prone here. If I want to identify levels, I sink off of the occiput and then I can be sitting on to C2. Yeah, so you won't be able to palpate C1, so the first palpable vertebrae is C2. If I want to orientate myself a little bit lower, I'll find the most prominent vertebrae, which is C7, and then I will get Karina to just lift her head, and C6 will disappear, and then she lowers her head, and then I can orientate myself on C6. So between those two we can palpate our way and have an idea of what level we are on. So what I like to do here is start on the top and just generally have a feel of the spine. So working my way down each level, 2, 3, 4, 5, 6 respectively, and then doing the same on the other side. And I'm having a feel if there's a difference. Again, you're bearing in mind the orientation of the facets in the cervical spine is 45 degrees, so your line of push should correspond with that really. And then what we can do is explore that in a little bit more depth. So we can start to use the Maitland grading system that most of you are probably familiar with. So 1, which I definitely wouldn't use these days, but it's kind of equivalent of bending the legs of a fly, and then moving into 2 and 3 into a little bit more resistance, and 4 resistance with a smaller amplitude, and then 5 would be a manip, which we won't cover in this video. And then I can work myself down each level and assess through range and see what am I feeling. Am I feeling resistance? Am I feeling stiffness? Probably more importantly, am I reproducing symptoms or pain?
Yeah. And you're using your thumbs to do.
So for this, I'm using my thumbs.
And sliding off onto the.
Again, I'm on the facets. Some people will go directly onto the spinous process. For patient comfort, I find facets much more comfortable for them and for me actually, and I can feel a lot more that way. So they're the two. If you look at the two videos, they're two quite different ways of doing the same thing. And me and Chris were just having a discussion about this actually, the accuracy and the evidence, and how much importance we should place on the evidence when we're teaching this or practicing it. And certainly in my head, I don't want to throw away everything that I was taught and everything. When I went through my postgraduate stuff, it was very much specific palpation as well. And to me, I think there is a benefit in that, in the sense of it's all to do with your intent, I think, and what you perceive you're doing, and what you tell, more importantly, what you tell the client. So it's been established now that we can't really accurately say, oh, I'm on C3 and I'm in mid-range of that vertebrae. I think we can all accept that. But if I'm having that in my intention when I'm palpating, in my mind it makes my handling skills better. So I don't think we should just say, okay, we can't tell what level we're on, so let's just be really fluffy and work around the neck. I think that would promote poor handling skills. Yeah. On the same note, I don't think we can turn around to the client and say, oh, your C2 is stiff mid-range and I'm going to do a mobilisation on that. So it's an interesting time really for manual therapy. And yeah, I don't know what your thoughts are.
Yeah, no, I completely agree with that. I think we were just saying that I think you almost need to hold two conflicting views in your own head at the same time, but know that and not tell the patient about that. So it's almost like you were saying then, I think thinking that, you know, for example, the facets are in 45-degree angle, so you're going to go in this line of pull. Thinking that as you do it, I think does make your handling skills better. And there are obviously different points of view as to whether people can have better or worse manual skills, but I personally think you can. But in your own mind, knowing that you can't say, like you said, whether you're, you know, they're stiff at C2, 3 at mid-range, and therefore you're not going to tell that to the patient. So I just think that in your own mind, you're thinking about manual handling in a certain way, or manual therapy techniques in a certain way that's more traditional, purely to make your handling skills good. and then it's the way you're interpreting that information into not only treatment but into what you're saying to the patient that will probably differ from the traditional. Does that make sense?
Definitely.
So you are doing things traditionally, but then you're, in terms of your treatment and how you're explaining it to the patient, you're doing things more from a more of a modern viewpoint of neuroscience and of the evidence. That's kind of how I think about it.
And I think the key way to put that to the test really is to actually put yourself in the patient's position. So partner up and work through the PAIVMS in a variety of ways. So one time you're going to completely focus, you're going to set yourself a target, okay, I'm going to do a grade 4 mobilisation of C4. And then the next time you do it, you're just going to palpate and press around C4 and try and mobilise it without having too much intent about that as your specific handling, and see how it feels yourself, you know, because certainly from my point of view, there's a real difference in people that are trying to be specific and using their handling well to people that are just pressing around there and not really having much attention on where they're putting their hands. Now, whether you're accurate is a different argument, isn't it? But certainly from a comfort point of view, which will then promote confidence in you as a therapist, and then will increase compliance to any exercises that you give. I think it's a core skill that we shouldn't lose, but we just need to modify it with the current way of thinking. Yeah,
and it reduces threat when we know that threat is part of this, but psychological element to pain and to patients getting better. So I think that's a key part of it as well. And I think the better you're handling, the more the reduced threat. So yeah, I think it's an interesting one, but from a technique point of view, this has hopefully showed you a good variety of ways, obviously with the supine work as well, that you can do the accessory motion testing. Hope you enjoyed the video, guys. If you did, then please give us a like and subscribe by clicking up here. Also, don't forget to go over to strengthphysio.com and check out our members area, which has basically got our full library of all of our videos. You can get there by going to strengthphysio.com/members. Hopefully I'll see you on the site, and I'll talk to you all soon.